There we go. So yeah, so this year I went, all right, well, I know what to expect now because I was there last year, and I felt like we had accomplished some things this year at the foundation, and we had. So what do I come away with it this year? And this year, if you remember, I specifically went with the idea that, okay, the foundation's great, but what the foundation is for, and the reason I'm going to these things is for the patient community, because what good is it if we're not helping the patients? So that was really my focus this year, was to try and get as much information as I could about what we need to do as a group, as a community, what the foundation can do to help um, make that stuff happen. Um, and that was my focus this year. So one of the first things that happened was, and like I said, I'm going to go to my notes here, so forgive me if I seem like I'm not reading or looking at the camera. So the way the summit worked this year was we had a whole bunch of different sessions, and you could choose which ones you wanted to go to. One of them was mandatory. It was the first one for anybody who NORD paid to go to the summit, which they did for me. They paid for my airfare and hotel, so that meeting was mandatory. And the way that worked is it was a whole room full of small tables, and each table had a different subject. So they were all um, roundtable discussions. The table that I was at was about volunteering. Most of the people at that table were in bigger organizations that were more established than we are. But my focus, what I wanted to know, is how do I get people to volunteer in our community, and how do I get people outside the community to volunteer? So that was very important. The one thing that was really eye-opening about that session is that NORD actually has um, a way for students, either high school or college, if they're interested in volunteering. It's called Students for Rare, and it's on their website. And so I have to get on there, or somebody has to get on there and see, where are these kids? Where are these college students? Are they only in America? Because NORD is an American organization, obviously, but I'm sure there are organizations similar to that in other parts of the world. And what can we get these people to do for us beyond the foundation board and the medical advisory board? So one thing that's really important about the foundation, um, sorry, there was another admission warning here. One thing that's really important about the foundation that I'm really working to try and get is, we need the foundation board to be the community. We need it to be patients and caregivers, because the foundation is centered on us. It's centered on people like myself and like um, Elizabeth's daughter and Anne Marie's grandson, and we need, the board itself should be us. The doctors that we have involved right now, which are wonderful, and we have 6 of them that are involved, they should be their own board called a medical advisory board. This is something we knew last year, and we're working towards that. I am trying to get more people involved. The ABL Foundation is not an American organization. So Kenneth, you're in Denmark, I think you said. We
Yes.
need people. We need people from anywhere who want to get involved with us and help us push the foundation further and grow it and make it bigger. And then once we do that, once we get a representative board, maybe 5, 6 people, something like that, then we can take the doctors and split them off to their own board called the medical advisory board. That's how these foundations are supposed to work. That's how the bigger foundations work, is they have their senior board, which is all patients and caregivers. and then the doctors are on their own, because they shouldn't be the ones making the decisions, is what we learned last year as well. So if you have any interest, or you have family members who have any interest in becoming more involved, please, let us know, because we need more people on the board. So, um, but so then above that, we just need volunteers to do stuff. I need a Barry to help me do the podcast, because I had no idea how to do that stuff. I needed this guy Sean is building this new website for us. So uh, other volunteers that will just help us make things happen that we need to happen. If we want to do fundraising, fundraising, we've talked a lot about fundraising, and we go, okay, well, what are we raising funds for? This today is one of the things we raise funds for. The fact that we have a paid Zoom account now is thanks to the pharmaceutical company that Anne Marie gets the vitamins for her grandson Lewis, who has A beta. She contacted them and said, hey, will you help us out? They donated some money to us. That money has paid for Zoom. So that's the kind of thing that we need money for. Now, eventually, excuse me, it would be great if we could find different ways, whatever ways possible, to subsidize people getting their vitamins, because we know it's very expensive. And excuse me 1 second here. Let me mute my thing here.
Paul, are you speaking to us? You're still muted.
Sorry, thought I hit the button. I guess not. Um, so yeah, so fundraising, there are different things that we can do with funds that we raise. We need to pay for the website. The website is a paid domain name. ablfoundation.org is a paid domain name. So we need to do that. Pay for Zoom every year. It's $150 a year for Zoom. But yeah, we would like to eventually somehow help patients and caregivers get the vitamins that they need, and that's going to take money. And the way to do that is to fundraise. So what we could do now, Anne-Marie has been working on trying to get Facebook, or whatever the hell it's calling itself these days, trying to get Facebook to allow us to do these fundraisers that you see people post on their birthdays. Hey, it's my birthday, please donate money. And I tried to get them to allow us to do it when we first created the foundation, and they just kept turning me down. And I got kind of frustrated, and so I stopped. Um, there is a process that they have where you have to submit all of your paperwork, everything that proves that you're a 501c3, and they hopefully then will approve you to post these types of fundraisers. But we don't have to use that. We can, and if she gets them to finally agree to that, that would be awesome. But if not, there are other ways. We can do a GoFundMe. We can do um, we have a donate button on the website. It will be on the new website as well. That takes people straight to PayPal to donate. Um,
Paul,
people.
just so you know, PayPal and Meta are actually now in bed with one another.
Mhm.
And so it's actually all one in the same process. And it's actually become political. You know
Mhm.
how Meta became political with everything with the last election cycle? It's all a nice web of things. And it's something that I want to talk to you about. I think we would be better off researching another vehicle for donations.
Okay. We can certainly discuss that. That's probably something that you and I can discuss, but it also needs to be discussed by the whole board.
Yes, yes.
So we will tackle that issue. But
Mhm.
the purposes of fundraising, like I said, is to raise money for these types of things. And what we can do is, so I went on the NORD website, and I just looked up students for rare. I didn't have time to get into it, but they have a whole list of schools, just high schools and colleges all over the country, of they've told NORD that they have people that want to volunteer. They can do fundraisers at their schools for us. That's an easy thing to do. We would probably need to be able to provide them with documentation and maybe posters or something like that. But that is something we could look at doing. So that is definitely an area um, that I have focused on. Another thing, we one thing we really need from the patient community is we need their stories. We need everybody to write their stories, whether you're a patient or a caregiver. Write the story. I have mine mostly written. Anna Marie McPhail wrote hers. I know we have somebody else in the group who had a little um, booklet kind of thing published actually on Amazon. We need those stories. Those stories can go on our website, they can go on the NORD website. And what that will do is it will help us when we approach um, people for donations and stuff like that if we have actual stories. And one idea I had about using that Students for Rare is okay, I realize I have a bit of a, I wouldn't say a gift for writing, but I'm pretty good at it. I have a background in journalism and stuff like that. But I realize that not everybody does. People don't want to sit down and write their stories because they think they're not good writers. They think they don't know what to say. Um, so my idea was to contact uh, maybe a college that has a journalism course and say, hey, do you have anybody who would be interested in interviewing our patients or caregivers and writing their story for them? Because we can't we have people who have stories that don't want to write them for various reasons, whatever that might be, whether it's they don't have time or they don't feel like they're good enough writers. So I think that's something we could look at as well to see if there's anybody out there who would be willing to write our stories for us or help us write our stories. Um, so that was the first meeting. That was the first night that I was there. So one thing to know about NORD is the impression I get now, because now I have a better idea of what NORD Summit is that it is really geared towards um, pharmaceutical companies. Really, it's all about developing drugs and treatments for rare illnesses. That's really its main focus. So to be honest, there are some sessions that don't really apply to us. There are some sessions that are about things that are way beyond anything we have going because, with A beta and familial hypobeta and CMRD, there are no drugs. The only treatments are vitamins. And the big struggle we have is that drug companies and insurance companies don't consider vitamins to be a medical treatment. So we can't get anybody to help us pay for them. But when you go to the NORD Summit, that's not their focus. So a lot of the sessions were not 100% on point for us, but I took away a lot of things from some things. So one of the early sessions was they had a bunch of CEOs from pharmaceutical companies up there talking about their research into treatments for rare illnesses. And the biggest thing that I came away from that was they said that in the case of rare diseases, and we are very rare, we're considered an ultra rare disease, but there are some that are not quite as rare. But the big problem with doing drug development or clinical trials or anything like that is that there's not enough information on the illness in order to even start a clinical trial. And then if they happen to find one that they can start a clinical trial on, and they're a small pharmaceutical company and they're trying to develop a drug, if they get it to the point where they finally submit it to the FDA and the FDA turns them down, guess what? A lot of these companies fail because they put all their eggs in that basket. And then what happens is they get turned down and they have nowhere to go. Um, but the impression about there isn't enough information is a big deal that I really want to focus on in the next year. is we need to start patient registries. Now there are two types of registries. One is a database. It's an informational database that has everything about each patient that we can come up with. Name, well, not name usually, but date of birth, place of birth, who has the illness, what treatments are they having, do they have other illnesses, everything you can think of to find out about the illness and about the patients. Because what happens is when these researchers and when these pharmaceutical companies get together and they want to do any sort of research or clinical trial, is they look for a database because they want to see, are there enough patients out there that can give them a representative view of the illness so that they can do the research or the drug development that they need to do. So we actually just got, so Dr. Hussein, who is on our board, Dr. Mahmoud Hussein, works out of NYU in New York, and he just got approval from NYU to start a patient database for us. Now that database is going to be what they call, one of them's called natural history, and then the other one is something else. I can't remember the name of it, but that is more about collecting samples. They'll need blood samples, they'll need tissue samples, hair samples, stuff like that, so that the researchers can actually try and get to the bottom of it from a physical standpoint. So there's the information side, getting as much information as they can, and then there's the sample side. Obviously, the one that Dr. Hussein is going to do at NYU is going to require people to go to a doctor, hopefully maybe not to New York to do it, but go to maybe hopefully go to a local doctor so that they can collect the samples that they need and get them included in the study. But then on the other side is the informational one, and that's one that I'm going to start pushing on. I've developed a list, and Anne-Marie is going to hopefully give me some feedback on it as well, of a whole bunch of questions to ask from our patients and caregivers about each person that has the illness, whichever illness it is, because we do cover 3 of them. And I'm probably going to put that up on SurveyMonkey, which is a free website that does surveys. And we may need a paid account from that too. I'm not sure. Or we may just put it up on our website. But we'll need people to respond to that. We've asked a couple of times over the years for people to give us more information, and the response we got was very minimal. And we need a better response in order to develop that information. So that's a really big one. And that's where I came out of that session about what the CEOs and researchers feel about doing clinical trials and drug development. Is it's just very hard when you're talking about a rare illness because there's such a small database of people anyway. Which led into, there was a big discussion on gene editing. Now we've heard of gene therapies, and I think Anne-Marie, you asked me what's the difference between gene therapy and gene editing. Uh, the best way I can explain it, I think, is that gene therapies is they take genes that are not damaged, genes that are not incorrect, and they give them to a patient who already has an illness. Gene editing, I think, in a lot of cases, is about correcting the genes in the fetus before the child is born, I think is the big difference. And how they intend to do that, I'm not exactly sure, because I am, never mind, I hit the wrong button there. But they're working on that, and they talked a lot about that. Um, so one question that was asked, which I thought was a very interesting question and a very interesting answer, was somebody asked them if they thought that in the future, they didn't give a time frame, but did they think they will be able to cure most genetic illnesses? And their answer was yes, they thought they could. Every illness is different, obviously. How that cure has to be delivered would vary from illness to illness. I think in the case of the three that we cover, it would probably need to be done um, before the child is born, which means that obviously the doctors and researchers would need to know that the child has it. Um, there is testing that can be done to the parents to find out if they have the recessive gene. But even so, even if both parents have the gene, there's only a 1 in 4 chance that they would both pass it on. So yeah, they would obviously, in our case, I think, need to find out before the child is born that they have the illness, and then they would need to be able to deliver genes to the fetus that are corrected so that the child is not born with the illness. How they intend to do that in the future, I don't know, but they seem to be very enthusiastic about it, and and thought that it would certainly be possible in the future to cure most genetic illnesses, is the way they put it. So that was very, very big news to me, the fact that they think they can do that. And that led into the next session that day, which was about using AI, using artificial intelligence. Um, that's a
Mm,
big emerging field right now in medicine, is artificial intelligence. And they outlined 2 ways that they thought, for the most part, they'd be able to use AI. The first is to develop what they call virtual twins. It's all about doing like clinical trials and studies and stuff like that. Because when you're talking about a patient database that's as small as ours, where we only have 100 or so people in the world, and we really don't know how many we have because we don't know all of them. How do you develop a group of people big enough to be able to do a reliable study? Um, so they could create what they call virtual twins, which basically they would take everything they know about my physiology and they would create it in a computer as an artificial intelligent being, and they could treat us both. So that's one thing. They could treat the artificial twin that way to see how the AI's reacts, I guess is the best way to put it. And the other thing they could do is when you're talking about clinical trials, the other problem is getting enough placebo patients, getting enough people who don't have the illness that they could try a drug on, because of course people don't want to try a drug they don't know what's going to happen if they try it. So a lot of people don't do it. So they could develop using AI virtual placebo people, people who don't have anything wrong, and try the drug on them. So that was really, to me, that's really big news as well. That they think, I think between the two, gene editing and the use of AI, I think we're going to see a lot of progress in the next 10 or 20 years on treating or curing a lot of these illnesses. Maybe not ours, maybe ours. I don't know. We don't know that there's anybody working specifically in those areas on our illnesses, and that is something we need to try and find out. We need to see who is actually working on A beta, who's working on CMRD, and who's working on familial hypobeta, and what work are they doing, and how can that help us, whether it be now or in the future. Um, so we have to work on that. I think the board, the doctors and researchers on our board are going to have to really work on that for us, because they would know better than myself or Anne Marie or any of us know. So that's something we have to work on as well. And we need to find those doctors and researchers, and we need to get them involved in the foundation so we know what they're doing. And
mm,
so one thing I want to do with those people, with the people we already have on the board who are researchers and doctors, and any others that we find, is I want to start hosting webinars that we'll put up on YouTube. Not interviews, just, hey, tell us about what you're doing. What research are you doing as it relates to A beta? What research are you doing? What treatment are you working on as far as familial hypobeta or CMRD? tell us what you're doing, and it could just be them talking for 15 minutes, kind of like a TED talk or something like that. So I want to work on that as well, and that will be something I will be working towards. Um, so another session that impacts us here in America is the impact of the Inflation Reduction Act, which was passed late last year, I believe, maybe a year ago, somewhere around there. So there was a lot of discussion on that because what happens with rare illnesses is that they have so much medications in most cases that they have to take that can be very expensive. And if the drug companies are not subsidizing them and the insurance companies are fighting them as far as covering it, that can be very expensive. Um, so drugs can now be what they call renegotiated after either 7 or 11 years, depending on the drug. So what that means is, let's say they developed a heart medication, and through the use of the heart medication, they discovered over the years that, hey, that medication also treats kidney disease or some rare cancer or something. After either 7 or 11 years, depending on the drug, they could go back to the FDA and say, okay, now we have this treatment we can do for that drug. So that, but that takes time. And so that they're trying to reduce the number of years that it takes to be able to do that. And especially when they come across drugs that they already know can treat multiple illnesses, they want to make them exempt from having to be renegotiated, which right now they still have to be. So they want to make it so that if a doctor, if they discover that a certain drug is effective for treating more than one thing, that it immediately gets approved to be able to treat all the things that they can, which right now is not the case. So that's a big deal if that gets changed. The low income subsidy is going up on January 1st of 24. So if that is something you're here in America and you need assistance with um, getting drugs, that would be something that would be of interest to you. Um, yeah, the main thing about any drug development is still, as always, about affordability of the drug. Within 5 years, the FDA is hoping to see reforms in drug pricing, and they also want to find other ways to help patients save money on getting their drugs. So that's a big thing. Not so much for us for treating A beta or FHBL or CMRD, but what happens with a lot of rare illness patients, including quite a few of ours, um, is that they have more than one illness. And okay, maybe only vitamins treat our illness, A beta or familial or CMRD, but maybe you have something else that is treated with a drug. So that's still very important. Right now, the out-of-pocket cap in the United States is 2,000 a year. So if you once you hit $2,000 a year, you don't have to pay out of pocket anymore. The FDA is hoping to lower that cost in the future. So they are working on lowering that. So that was my big takeaways from the actual sessions, because like I said, there were sessions that didn't really maybe um, impact us quite so much. But there were other things that I came away with as well that I thought were worth discussing. One thing I'd like to do is I want to start for our adult patients and caregivers is I want to start a regular support group, whether or not that has any. And what I mean by that is like right here on Zoom. Maybe every month we get together and we can talk about what's going on. I think that would be a really good idea. I also had the idea of doing it for kids because I know we have a lot of children that have these illnesses, and maybe it could be moderated by a teenager or something, but that would kind of be up to the parents, and I don't know how that would work. But that was one idea I came up with. Um, we need to work on a newsletter. Maybe semi-annually, before the NORD Summit and after the NORD Summit, maybe, because it seems like I'm going to be going at least every year for a while. Um, so if anybody wants to tackle developing a newsletter, I would certainly appreciate the help, because I've tried and that's not something I'm very good at, graphics wise and stuff like that. Um, Sorry, I'm reading my notes here. Um, so medical conferences. So if we can find, and we've kind of dabbled in that a little bit recently, if we can find medical conferences that are related to our illnesses, such as here in America, we have the National Lipid Association. Contact them and say, hey, when you have your next conference, why don't you have one of our patients or caregivers speak? And because these are all the doctors who treat these illnesses. So why not get us in front of them? And we kind of did that a little bit with Dr. Hussein had Anne Marie McPhail come in. So Dr. Hussein teaches first year medical students at NYU. So they're very new students. And a few months ago, she posted about this in the Facebook group. He had her come in. He was giving a lecture on lipid disorders, and he just sprung it on the class. He goes, yeah, so we actually have somebody here who has a lipid disorder. Meet Anne Marie or Anna Marie. And Anna Marie walked in and she sat there and talked to the students about her situation, and they were blown away, because it's one thing to hear a dry lecture about an illness. It's another thing to meet somebody who has it, especially if you're a doctor who may look to treat something like that, or research something like that in the future. So we need to do more of that kind of thing. So we need to find out what medical organizations um, are having uh, meetings, that we can contact them and say, hey, would you be interested in having us speak? We could do it over Zoom. I could certainly facilitate a Zoom interview if they need us to host a Zoom meeting. We could certainly do that. They would probably do it on their end. But so medical conferences are a big thing to look at. We're gonna keep working on the podcasts. We need to develop a strategic plan. So one thing that has happened so far with the foundation is we don't really have a direction, a firm direction. We know we want to help the patient community. We know some ways we can do that, such as developing letters about the vitamins and stuff like that, and consulting when doctors contact us and say, "Hey, I have this patient who I don't know anything about A beta." So, but we don't have a really clearly defined plan. So that is something we need to at least consider, um, trying to build that. Um, like I said, we need to get more doctors and researchers involved. We need to develop patient registries, definitely important. Um, and I'm just looking through the rest of my notes here. There was a doctor, and I need to contact her. I think she spoke at the symposium, who was looking to do some vision testing for some studies she was doing, and she wanted to test some of our patients, such as myself, who have vision loss, I think, and probably some younger ones who don't. And we need to get in contact with her and connect her with the community. It's not so the sticky thing is the foundation can't be involved in promoting a study of any kind. We can't. We're not allowed to do that legally. We can't come to the patient community and say, hey, this doctor is doing this, you should get involved. But what we can do is we can say, this doctor is doing this. If you want to get involved, here's how you can contact them. And then it's between the patients and the researchers as to how they do it. Um, so we need to do that. I need to find out from her what she needs, where patients have to go. Can she help? There was some discussion that maybe she would be able to help financially with people traveling to get the vision testing that she needs done. So we need to find out if that's still a possibility. Um, but that's pretty much it. That's all the notes I have. Do you guys have any questions? Okay.
I have
Uh,
a few ones.
yes, please.
The vision testing, where is the doctor located? Is it in the States or is it in the UK, or do you know that?
As far as I know, she's in America. But
He's
I
American,
don't.
yeah.
Yeah, but I mean, if it's vision testing, if she gives a doctor in Denmark the parameters that she's looking for, she could probably facilitate for you there in Denmark to have it done. I don't know. I could certainly
Oh,
ask her.
okay. Yeah,
Because we haven't spoken to her very much, but we can certainly get into that some more and find out, do they have to be in America or can they be anywhere? Because if
yeah.
they can be
That
anywhere,
could
we could.
be nice to know. Our daughter Leah is going twice a year in Denmark here,
Hmm.
at the biggest hospital in Copenhagen.
Hmm.
And we are feeling really comfort with the testing they're doing, but we are, of course, you're always a bit scared they're doing it right, because she's the only one in Denmark, so they don't have anybody to compare with. So it's a
And
bit difficult.
how old is she?
8 years old.
Oh, 8 years old. Um, yeah, it's interesting. We seem to have there. There seems to be a gap right now. We have a lot of adult patients,
Yes.
such as myself and Anna Marie and Elizabeth's daughter, and then we have a lot of young children, such as yours, Kenneth,
Yeah,
and Anne Marie's grandson, who's 7. So we have. I don't know if there's a gap in patients or if we just don't know about those patients. My feeling is that there's probably a whole group in that middle section that we don't know about. Um,
I agree.
but I will look into that for you, and I need to fire off an email to the doctors this week and see if we can get in touch with her and find out exactly what that's all about.
Yeah, that sounds great.
Hmm.
Yeah.
Any other questions?
I'm not fully aware of all the other diseases, the CRMD and what they are, but my daughter has the beta. But
Hmm.
are there drugs needed to treatments to any of the other illnesses, or is it only vitamins, all of them?
As far as I understand, the 3 illnesses that we cover, which are A beta,
Yeah.
familial hypobeta, and chylomicron retention disorder, they're all different mutations of the same gene. And as far as I know, and this is something we need to develop for the website as well, but as far as I am aware, they're all treated with vitamins.
Okay.
Um, One thing I am working on, or going to be working on, for the new website is I want to put together a um, probably a video with text in the background where I'm just talking about what is A beta, what is familial hypobeta, what are the symptoms, what is the treatments, how do you get diagnosed, that kind of stuff. Now, as Anne Marie pointed out to me when we discussed it, we have to be careful not to be giving medical advice,
Yes.
because every person is different, obviously. But I think there are general things about each illness that we could relay, because what happens a lot, and I've seen this in the Facebook group, I've seen it in contacts that we get from people through the website. What happens is, patients or caregivers, they come to us and they go, we just heard about this illness, we don't know anything about it, tell us what it is. And we go, okay, well, we know what it is from our own personal experience. So there needs to be a basic, this is what these illnesses are. Your your experience may be different because every
Yeah.
human is different, but I think there is a baseline of things that we could relay through the website to educate people on what these illnesses are, so that they could be better informed, if nothing else, so that they could go back to their doctors and say, okay, this is. So well, another thing we have is we get a lot of people who think maybe they have it, they don't know. And my answer always is, no offense, but you probably don't, because this is so rare that
Yes.
chances are you have something else. Um, but at the same time, if you listen to the podcast, what we talked about a lot on the podcast is we need to get doctors tend to, they go, oh, you can't possibly have that. It's too rare. Well, they need to consider every option, and
Yes,
they need to know what are the telltale signs to a doctor that, hey, I got to look at familial hypobeta. I got to look at CMRD. What are the signs that should tell them immediately that this is something they should consider? And there are some very obvious signs. Extremely low cholesterol levels in A beta. You know, mine is 45. It's never been above 50 my entire life. Acanthocytosis, which is irregularly shaped red blood cells, which they can see under a microscope. All they got to do is draw some blood from the patient and stick it under a microscope. And if they see these red blood cells that look like spoked wheels, that should be an instant
So,
notice to them that, hey, this is something we got to look at. But they don't. And they do every other test. Oh, it's got to be this. It's got to be that. It's got to be this. And it takes them months and months. You know, it took my mother 9 months almost to get me diagnosed back in the 1960s. Here we have Liz's daughter, who's younger than me, quite a bit younger. It took her 9 months. And that was after 20 years after I was diagnosed. Why
and
did it not progress in that 20 years to a point where somebody could have said to Liz, hey, maybe it's this after 3 months? You know, because it's a big struggle. We call it the diagnostic journey or the diagnostic odyssey, because with any rare illness, and this was something that came out of NORD last year, with any rare illness, these people go through these long journeys of trying to get diagnosed, and nobody knows what's wrong. And they keep telling them it's one thing or another. And there are things we can do as a foundation and as a patient community that can point doctors in the right direction. But we need to make them aware of them, and we need them to be open to those suggestions. And so it takes a lot of work on both ends. It takes work on our end to develop that information so that when a doctor comes looking for information, they get the information they need. But it also takes education on the doctor's side of it so that they know to think to look at these things. And that's why I talked about going and trying to speak at these organizations when they have meetings. The National Lipid Organization here in America, we should have somebody there every year. I mean, really, this is a very rare lipid disorder. The fact that they don't even know about us really is criminal. They should, and we should be speaking at their conference every year. So that's about educating the doctors. So that it's a real hard thing, because we're at the foundation, we're in the middle. We're trying to educate the patient community, and we're trying to educate the doctors all at once. And it takes a lot of work, and we need more people to help us do it. So if you have any interest in helping, please let me know. Because right now it's myself and Anne Marie, and we have board meetings and we talk about stuff, and the doctors, they help a lot on their end when they can, putting us in touch with people. But they don't, as far as the legwork of developing the documentation we need, that's all going to have to be done by us. One last thing that I almost forgot to mention to you guys. So when you go to NORD Summit, they have a social media app called Jujama. And in Jujama, you can see everybody that's going to be at the conference, everyone that's going to be at the summit. And you can try and contact them and arrange to meet them while you're there or whatever. So I thought about it, and I went, so the week before the summit, I researched and I found every single person that was going to be at the summit who had some sort of tie to a pharmaceutical company. And I sent a message to every single one of them. It was over 80 people. And I said, this is our illness. We take these massive doses of vitamins. One thing we really want is we want to have a formulation that has a massive dose in a small package. Myself, I take 36 vitamin E pills a day. I'd rather just take one or two, but I'm stuck having to take 36 because the only dosage it comes in is 400 IUs. I want somebody to develop the same vitamin in a large dosage delivery system. And I said, is there anybody out here that's going to be at the summit? Any of you people who all work at pharmaceutical companies that can help us do that? And one person responded to me, and she told me about a company in Canada called VitaHealth, I think is what it's called. And she said, contact them because she thought they were already working on that. So I said, oh, great. So I've already emailed the doctors on our board because especially Dr. Deckelbaum is in Canada. And I said, do we have anybody that knows anybody at this company? And if so, great, put us in touch with them. And if not, then I'm just going to write a letter and explain our situation and say, can you help? Maybe they can help us develop the vitamins and the dosage that we want in higher doses. Maybe they can offer us a subsidy or a discount for group purchases or large dosage purchases. I don't know, but we need to contact them and find out. So that was, to me, that was the best thing that came out of the summit, was that I actually got a company that maybe we could work with. I know that Anne-Marie's been working with Callion about Lewis's vitamins, and maybe that's something they can work on as well. But that was really cool to me that somebody finally actually said, yeah, maybe there is a company that can do that for you. So if anything comes of that, I will certainly let everybody know, because that would obviously be a big deal. Now, the interesting thing about the vitamins, and we have Kenneth here with an 8-year-old and Anne-Marie with a 7-year-old and Liz with somebody who's closer to my age and myself, the dosages are vastly different for the
Yes.
children compared to the adults. But that doesn't mean we can't have something developed that delivers the dosage we need, whatever dosage that is for our kids or for us or whatever. So that's I think we could. I'm hoping we can get a lot of help from that company.
And especially if it could be developed in a liquid form, because it's much easier to dispense varied doses in a liquid form.
Exactly.
We have a liquid form here in Denmark.
Is it Aqua E?
Sorry?
Is it Aqua E?
No, it's called something else. I can show you guys on the screen here shortly.
Liz, I'm sorry, I can't remember your daughter's first name. What is it?
It's Leah.
Megan.
Leah.
Do you have any idea what dosage Megan's taking?
With the vitamin E, she's probably taking around like 26 a day.
26. So she's not too far from what Paul's taking.
Yeah. Yeah.
And really, and I discussed this during one of the podcasts. I'm at 36 only because my doctor said, well, that's about the most we think you can take without it being toxic. It's like, oh, thanks. That's good. And the problem, especially with vitamin E, as you know, in A beta, is it doesn't matter how much you take because they can't figure it out.
And Kenneth, what was yours called?
Sorry, one more time, Anne-Marie.
What was it called, Kenneth?
It's right here. It's called alpha tocopherol. I don't know. Can you see it on the screen there?
Yes, alpha tocopherol acetate. Okay.
I've heard of that, I think. And that's vitamin E, is that correct?
That's a vitamin E, yeah, with no oil or anything. It's water-based.
100 milligrams?
Yes.
And what are the IUs in that? Can you see what the international units are?
No, not on this one. It's only set in the local ones. In ml, it's mg, ml. I can't see the.
And how much does Leah take?
7 milliliters a day.
And
what was that? 7 what?
7 milliliters.
7 milliliters a day. Okay.
Yeah.
And does she take A or K or D?
Nope.
Interesting.
She's covered.
What about Megan?
I want to know, has anyone had a high vitamin D level? Because she just was seen by the doctor, what, 2 weeks ago, and her vitamin D level was out the roof.
Yeah, Leah's too.
Yeah, you know
Okay.
what? I took vitamin D when I was a young child, but I have not taken it in decades. They say that's not really a problem for me, and I think it's not really. It is a problem for some A beta. I think it's really a problem for younger ones. So
Yeah,
I would.
Lewis
Lu-
is still taking D, but his numbers,
Mhm.
indicate that he needs to take it.
Yeah, and I think what you'll find is when he gets older, you may not need that.
Mm-hmm.
But again, every patient's different, so who knows? But
Right.
yeah, my experience has been that the young ones all take the D, and then once they get older, they just go to A, E, and K.
Mm-hmm.
So
But
that's
Leah's numbers are totally crazy indeed. They're going out the roof as well. So she's not having any D. Not at
Now,
all.
let me ask a silly question. Lewis is non-mobile, so he doesn't get outside a lot in the sun to get the natural D. Um, does your daughter get outside a lot, Kenneth?
Yes, every day.
Son?
She's totally normally functional. So
Okay, and of course, Megan is out and about all the time. And that could be a difference with Lewis because he's
yes.
non-mobile. He doesn't get outside much.
I
So,
don't get
mhm,
outside a ton, but I go through a gallon of milk about every 3 days, so that
okay,
probably helps me too.
yeah.
Yeah.
Um,
And see,
but
Lewis's diet is very limited because
mhm,
his only food is the Monogen formula
mm,
still. Mm.
yes.
Yeah.
So anyway, hopefully we will get somewhere with, I think the company was called Vita Health, if I remember correctly. That would be a game changer for us, I think, is even if we could get them to develop the vitamins in large doses, that's something we don't have right now.
Right.
So I think that would be great. It's interesting about especially what Leah's taking there. When I was a kid, um, the only place that ever developed any sort of liquid vitamin E back then was, of all places, Kodak, the camera company. They developed vitamin E for some reason. It came in a big coffee can, and it was wax, and we had to melt it, and then we had to mix it with water, and that
Oh,
was
wow.
the stuff I took for decades. They don't make it anymore. My dad used to buy it from them. I don't believe they make it anymore because they had a patent on it for many years. I don't know what they needed it for in regards to cameras or film, but they obviously developed it for some reason. Um,
Mm.
but yeah, that's what I was taking most of my life. And then when I started going to my current doctors at NIH, National Institute of Health in Maryland, they told me, well, we don't think it really matters if it's fat soluble or water soluble. You don't absorb any anyway. So just start taking the fat soluble. Okay. So that's why I take the ones that I do. It probably isn't helping much either way. But anyhow, that was the NORD Summit. Does anybody have questions for me? My plan, assuming I go next year, which I don't have to be the one that goes next year. If somebody else wants to go, NORD pays for somebody from a foundation to go. It doesn't have to be me. But if I go next year, we'll certainly have a meeting like this beforehand to discuss what things to try and concentrate on. And in the meantime, we're gonna keep doing podcasts, and we're gonna develop a questionnaire that we need to get patient information. And I'm gonna look into starting support groups if people want to do that. And we're gonna follow up on the doctor who's doing eye studies. So we got a lot of work. We got a lot of things to do. And if you want to help, please drop me a note. Send me a private message on Facebook or email abetafoundation@gmail or wherever you want. You guys know how to find me.
All right. Thank you, Paul.
Thank you guys.
Thank
And
you.
say hi to Megan
I
and Leah
will.
and Leah and Lewis.
Paul, before you go,
Yes.
um, Now I'm gonna forget what I wanted to say. Oh, can we get together one day this week to chat about a couple things?
Text me when you have time, and I'll let you know.
Okay, all right, sounds good.
All right. Good
All right, it's
talking
good
to you
seeing
guys.
everybody.
Okay,
Have a good
bye.
weekend. Bye.
Bye.
Bye.